All right, so let's go ahead and get started. Again, I want to welcome everyone to take the time and join us for our first session of the Clinical Intelligent Automation Council. We call it CIAC, or as Jason and I like to call it, is kayak. I think it's got a nice little ring to it. First of all, we're going to do a few introductions, and then we'll get right into it with our panel. And I'll explain a little bit more about what kayak actually is before we do that. So today, the moderators are myself, Jeff Hatfield. I'm Vice President of Intelligent Healthcare Automation. I also lead Ashling Health, which is the healthcare vertical division of Ashling Partners. Jason, introduce yourself.
Absolutely. Good afternoon, everyone. And thank you again for joining us today. I do represent UIPath in this conversation. I lead the global healthcare and life science practice. A lot of my focus here is definitely in the United States and the practice of care end to end. Thank you again, and look forward to the conversation.
Fantastic. Jason, you want to keep going and just tell a little bit about UIPath?
Sure. Happy to. So for those that work closely with us, we are a leader in the robotic process automation space. For those familiar with Gartner and Forrester, we're in the top right-hand corner. And we've been leading for the last 2.5 years now. What people might not know is that we have a very heavy healthcare footprint. Actually, the second largest revenue stream for UiPath is healthcare. And that is because of the way our technology works. It's because of the way that we release our products. And it's also because we talk the love language of healthcare, which is very important for a lot of the folks that are on the call right now. And I know a lot of you, I see some familiar faces. So we've been very blessed to be able to work with some of the top health systems and really innovate in spaces just like clinical. Jeff, guess I'll toss it over to you.
No, that's great. And so Ashling Partners is one of UiPath's largest SIs. I think we might be the largest in North America. And we work with the entire platform of UiPath. So not only do we work in the automation space, but we can also do the process mining. And we do a lot of value engineering. We've helped build out a lot of strategies and roadmaps for our clients. And then on the other end, we also do intelligent automation, natural language processing, document understanding, the whole bit. As I said, Ashling Health is a division of Ashling Partners dedicated strictly to healthcare, and that's both on the payer and the provider side. Jason and I go back quite a ways. We worked together for a number of years prior to Ashling and UiPath. We both worked at Express Scripts and co-led their specialty drug transformation of the business. And we both share a very, very strong passion for leveraging today's technologies to help make a big improvement in healthcare. And one of the things that he and I have been observing over about the past 1.5 years, I think, maybe even longer, Jason, was that while automation has caught hold in healthcare in a lot of the back office areas like HR or claims, finance, RCM, there has not been much of a success and much of a push to get that same type of success in the clinical space. And we feel like that's where the biggest impact to healthcare and including patient outcomes is going to be. So we decided that we would try to do something about that. And so that's where we came up with this council. And the purpose of the council is to do exactly what I just said. It's like, let's figure out what types of things, what type of opportunities are there within the clinical space that we can use intelligent automation to actually make a difference. Can we speed time to treatment? Can we improve patient outcomes? Can this technology be used to reduce surgical waste? And those are things we're going to talk about. So the council is here. It is a collection of senior medical and intelligent automation leaders within the industry. And it's by invite only. We have part of the team here today that's going to talk through and start identifying potential solutions. That'll be the purpose of today. We'll meet quarterly, and in those quarterly meetings, we'll have those open to the public because we want the industry to hear what these experts are saying, what kind of challenges, and understand what types of solutions that we're working to develop. In between quarterly meetings, we'll have breakout sessions where we'll actually do solution design, and eventually we'll get to solution build. We feel like this is going to be the best way, again, to make that kind of impact on the industry. Jason, do you want to add anything to that?
Oh, so one, Jeff, fortunately, when we gave you host rights, there might be people waiting in the lobby. So you might want to check real quick to see if anybody's trying to get in. And the thing I would like to encourage and really give some prospect of why this is important to us is we do have a couple other user groups. I have a user group that focuses on revenue cycle. We just talked about back office, right? I do have a user group that focuses on machine learning and AI. It's pretty successful. We find that when we're working together, we can find outcomes faster and really have a good talk track around why this is. Oops, got on mute. I don't know if that was on purpose, but
no, it was not.
Well,
I was
okay. It took me a stance there. But this is the encouragement part. The one thing I would encourage this team is it's not really a technology issue anymore. For those technologists on the phone, those that work with automation, it used to be a hurdle. Well, there's a data issue, there's a process issue, there's a technology issue. Well, we're finding that a lot of organizations aren't burdened by a technology issue anymore. They're burdened by a change management issue and finding a qualified way of approaching things like improving clinical care or reducing administrative burden. A lot of it is because of the P in RPA, robotic process automation. And as we all know, especially in the clinical space, sometimes what we do on a daily basis is just as unique as the people that are being treated with those processes, right? So I would say remove the P from RPA and start thinking about what is the problem? What is the design that I need? It's that agile center human design of user stories. And we find when you take it from that construct, then backing into a platform like UIPath that has the ability to run robots on the desktop, to be able to create UIs, to be able to integrate chatbots, the solution comes together really fast. And next thing you know, it's like our friends in Ireland, they're servicing 11 million members across the whole Ireland base because now they're achieving clinical outcomes at the desktop. So this couldn't happen if we don't think about the problem first. So I just encourage this team to think of it from that perspective as we go through this process.
Awesome. Thank you, Jason. All right, with that, let's jump right in. I can get back to here. Okay, so here are our panelists for the day. These are all our council members today. Dr. Ephraim had to step away. He had a conflict. We knew that going into this. He will be back at the top of the hour. And let's just go left to right across the screen here and introduce yourselves. Introduce yourselves. Let everybody know your organization, your role. But then I'd also like to hear what inspired you to join Kayak in the first place. Okay. Benjamin.
All right, I'm up first, and hopefully you all can hear me.
Yep.
My name is Benjamin Berkowitz. I'm the Director of Intelligent Automation for Mass General Brigham, which is the corporate entity for Massachusetts General Hospital, Brigham and Women's Hospital, as well as a few dozen other hospitals that come within our system. We leverage both RPA technology, OCR technology, machine learning, natural language process, and actually have just started in the era of process mining and task mining as well. So we're still relatively new to the space as well. Been around for a couple of years doing this work, and we have 80,000 employees across our system. Right now, most of our automations are back office, as Jeff was mentioning, and we're really looking to expand and find some ideas of how to move into the clinical space. The passion for me around this topic is similar to the passion around the automation in the back office, is really reducing the amount of work that our staff are doing. And in particular, in the clinical space, when you think about physician burnout or nursing overload or overtime, are there ways to mitigate those challenges that we have using various types of automation and using various types of technology? And I couldn't agree more with the comment made earlier about it's not the technology anymore. It's really about finding the right processes. And I would add to that really about educating individuals about what this technology can and can't do and how it can help them. And that's where I see my biggest role and impact.
All right, I'm Martin Knowles. I'm a vascular surgeon in the UNC healthcare system. I work at UNC Rex Hospital in Raleigh, North Carolina, where I'm the chair of surgery. Have a dual role where I'm also the chief medical officer of a company, OpFlow, which really has been laser focused on automation, lean efficiency, cost savings in the surgical space, and have saves money by creating lean processes with surgical instrumentation, supplies, and then preference card status to make surgery run cheaper, more efficient. And so really have always been very interested in the intersection between, clinical care, technology, and business. And I couldn't agree more that really vast majority of what we do is change management and setting expectations around that, rather than actually whether things should be done, could be done. It's really convincing people that it needs to be done, I think. And then a dual role of also showing that what you're doing brings value to the hospital and isn't a sunk cost for them. And so very interested to be here. Obviously, I think my interests align very well with Kayak, and why I'm excited to be here and chat with everybody.
Good afternoon, everybody. I'm Stephen Heimbigner. I'm with Piedmont Healthcare. The Piedmont's a rapidly growing healthcare system in the state of Georgia. At the end of this month, we'll be 15 hospitals, and we've got 2,500 providers in our physician hospital organization. My title is Executive Director of Clinical Analytics, and we've been on the journey of intelligent process automation for about 2 years. We've grown a very successful program. It's very exciting about some of the things that we've done. I personally have gotten interested in participating in Kayak because I'm a big believer in process automation. We're all dealing with limited resources, and the opportunities that we're able to do through intelligent automation allows us to do more and do more for our patients. And that's very exciting. There was a statement that was made to me in the past. I can't remember who told me, but one of the slogans that we like to use is taking the robot out of the human. So we pride ourselves in being one of the top 10 employers in Georgia. And when we can take the repetitive tasks out of our staff's list of responsibilities, we allow them to focus on some of the more critical thinking tasks. It really helps us to be more dynamic and more efficient.
And my name is Brian Busby, and I'm our Director of Clinical Analytics. And so Stephen and I have been working on the RPA team for the last couple of years. As he said, I have long supported our value-based contracts in accountable care organizations. And I've long been fascinated with how you drive clinical outcomes, reduce costs with a finite set of resources. And we built out a couple of pop health departments, and we've been focused on how we can have the most impact on the couple 100,000 patients without growing that cost structure. And so the ability to start using this type of technology and this type of tooling to improve patient outcomes and drive down costs is what really got me wanting to come and learn from this group, figure out what other folks are doing, and see how we can better engage with clinical staff who don't have an appreciation or an understanding about this type of technology, what it can do for them, or how to approach these types of problems, and help them think about it in a different way. And that's what I'm looking forward to getting from this group and sharing with this group.
Awesome. Thank you, guys. All right. So for today, these are the these are obviously key objectives in the clinical space, and they're categorically, they're quite broad. And so what we wanted to do today was talk about these. Whoops. I'm going to go off presentation if that's okay for everybody, so I can take notes here as we go. So speeding the time to treatment. So high risk pregnancies, high risk patients. Sorry. For a long time, there's been a lot of data, tons of data, and a lot of good analytics. And those analytics provide us with insights as to how can high-risk patients be better treated. But many times it doesn't really help in speeding time to treatment because there's such a huge amount of time up front just gathering information, gathering data, cleansing it, pulling it together, and then on the back end, taking the information that comes out of analytics and actually getting it out to the provider or the patient in the right way. So that's one that I've been working on for a while. We've done some things there. It's one that I'd like to, throw out and see what thoughts are. Reducing surgical waste. This was Martin's. He brought this one up. He's done a lot in his area. We're doing things with supply chain within healthcare. We're doing process mining so we can map everything back to kind of like that last step where it's actually sitting there in the surgical center. So there's some gaps in there that I think we can probably figure out that we could possibly automate. Avoiding HACs and DI trending. Someone, I think it was Stephen or Brian mentioned reducing early readmissions. To me, this is all about the quality of care, specific on inpatient, and what happens during that cycle, during that stay from admission to discharge. And once again, there's a ton of data being captured, but is it being looked at and analyzed quickly enough to where we can see someone trending towards sepsis and we can have the bot can notify, the nurse, the floor nurse, whoever, to say, hey, need to go take care of this right now. And then finally, just overall improving patient outcomes. Again, back to Piedmont, we talked a lot about yesterday. You guys are very passionate about this, going all the way from, how do we improve registries? How do we automate that? How do we take that data and get it out again very quickly so that there's a constant learning and constant improvement on patient outcomes? And then how do we continue to stay with that patient? Stephen and Brian were mentioning yesterday the backlog that they had, where they had to, make sure that in the oncology area, make sure that they're still keeping in touch with those patients. A lot of opportunities there as well. So that's just kind of my read on it. It's the whole group. We've talked ahead of time. We've all agreed. What we'd like to do now is say, okay, what do we think? Are there some things that we should be focused on from specific solutions? And anybody want to start? Anybody want to pick one over the other to start with? Martin? Put you on the spot.
Yeah, no, I mean, obviously I'm going to key in on the one that I live and breathe every day. But, I think,
thought you might.
But to be honest, I really, that's the one I'm really passionate about. But these are all big issues, and I can see that we could really start with any of them. We've spent a significant amount of time in the last couple of years just figuring out, for either getting high-risk patients in, avoiding early readmissions, improving patient outcomes. A lot of that has been, those decisions have been made based on data. And so, I think one of the things that we look at is where are we getting the data from? How reliable is the data? How do we show that data so we can make actionable changes with it? Is it structured? Is it unstructured? How do you really put it in the hands of clinicians who are going to understand what you're showing them so that you can make some sort of decisions? We found easy things such as identifying high-risk patients after they get discharged, calling the patients to check in on them afterwards, and the decreasing, readmissions that come from that are all big things. So, I mean, we could talk about all of these, and I think there's probably, an entire day's worth of conversation in each one of these. But I think a lot of the overlap between them, if we're looking, is, how reliable is the data? Where is the data? How do we visualize the data? And how do we make actionable decisions on that, and then how do we actually impact change?
And I can add a little bit about that because we've had some conversations in my organization around the data collection piece and using RPA for that component, particularly around infusion reporting in our example, which is, how do we get the information to the clinicians as soon as possible so they can understand how infusion and the infusion chairs are being utilized. But taking it a step further, are we optimizing our infusion workflows and our infusion scheduling, right? So, making sure that we can get patients in at times that are convenient for them, but also making sure that we are keeping those chairs, for lack of a better term, warm, right? And that they're not cold, and that we're optimizing the use of them, because those are very expensive treatments. They're for high-risk patients. And we want to make sure that everyone can be seen at a schedule that works for them and works for their physicians in terms of when they need that treatment.
So honestly, to follow on to that, we had the exact same process and found that even the time of the day that you bring the patients in for the infusion impacts the number of beds and the likelihood that patients need to stay overnight, and how much you tie up hospital beds, which these days is, for us at least, is a absolute commodity. And so, just in even identifying, what's good for the patient to come in and what's good for the hospital, and trying to find that dynamic. So, starting an infusion at 3 o'clock in the afternoon increases your risk. You're going to have to keep the patient overnight, tie up a hospital bed, versus trying to get them in the morning, move them to outpatient facilities, make sure they're not in inpatient facilities for it. So absolutely.
Have any of you heard of any, when we get into like process mining, which is becoming a really big area. If you think about that, it's part of UIPath's platform, but it allows you to take transaction logs from basically any system and read those and map out, okay, here's the process flow of thousands and thousands of processes that have gone through, and you can see and pinpoint where the different bottlenecks are and where you have examples like exactly what you just said, Martin. So there's been some talk about using process mining for patient pathways. Have any of you seen any of that, or have any of that come up at your organizations?
So
that would be.
We use process. We have process mining at our organization. We're new to it, so we haven't quite got into the clinical space with it. Where our use case is a little bit more between the research and clinical billing, because those workflows are quite complicated. But what I'll say to that point, we're an Epic shop. A lot of organizations are. It really gives insight as to if we are following the prescribed happy path that we had designed years ago when we went live with Epic. And it's quite, it's quite interesting to see how much deviation there is from that happy path that we thought we had designed really well, or was out of the box when we installed Epic. And there could be very valid reasons for why we're no longer following that, but at least it gives us some indication of all the different paths. And additionally, it gives insight. We also want to use it to track the bots that we currently have live right now, because one of the challenges that we've sort of stumbled into when we first went live was that our bots were creating additional work downstream, down the process stream. And the bottlenecks were occurring where there were still people involved, right? So all of a sudden, Mary's work queue went from 50 a day to now 1,500, and that didn't help Mary at all. So to have a little bit more of a visual in terms of the overall impact of putting something, an automation live, whether it be RPA or machine learning or intelligence, is really important as we think more holistically about how to deploy automation. So imagine Mary now is, instead of someone in the billing office, is a physician or a nurse that has a tremendous work queue. So that's how we are thinking about that type of work.
Yeah, great point. Jason, you want to jump in? on anything?
Yeah, it's a great conversation. Very, very interested in the conference, right? And more streamlined, easier to manage and maintain. So the question is, you know, obviously automation can be used to streamline the insights because it's very diverse and crosses multiple applications. I think we get that and understand that it's a big topic. But then when we get to action, right, you find a lot of times the action is put on a workflow. It still requires a physician to check a report, check a box, do some research, enter data. There's still action. Someone has to take that action. But when we speak with health systems, we find that 30–40% of that action is actually something a robot can do. You can automate it, or automate the process in conjunction with we lovingly call that human in the loop. But if it requires 3 pieces of information, that's a judgment call by a clinician, and then the rest of that step through process can be done by an automation, that's where things get interesting. You start to take 2 to 3 hours of abrasion off of a clinician's time a day.
Right.
So I'm interested to know thoughts of, you know, are you seeing those opportunities within your clinical staff? Are you reaching out to those opportunities today?
So we've, over at Piedmont, we've identified what we think is a really great opportunity. We've got a team of about 25 nurses that are outreaching to patients that we have at-risk contracts for. Mm-hmm. They're really limited by capacity, right? So they've got their productivity targets, they've been set, they're achieving them. But in reality, when we dug into the process and we started looking at all of the different patients that were in need of hand-holding and managing certain complex issues, our care managers were only able to reach out to about 5% of them. So we have such a demand for number of lives that we reach, who we can engage. And when we started evaluating the process, they were spending a huge portion of their time calling the patient, trying to sell the program to them, and then after that, they were able to start that process, the actual value added component of the process. And so what we're trying to achieve with this technology is use a bot to sell the program, sell the benefit of it, and quickly identify those patients that are willing to engage, so that managers can no longer have to spend 30 or 40% of their time trying to convince somebody to engage with them, and instead use this technology to create a tool to say, look, we can take that productive, like, you know, they're meeting production targets, but we're trying to take that productivity, that true productivity, from 60 to 90, 95% by having a pool of folks that are in need of their services and willing to engage, and just feeding those patients and having them experience value at a time.
Yeah.
So it's a combination of what we call the intervention. So you have patients that may be post-discharge that are out in the community who need very specific interventions. So number one opportunity is some of the interventions can be done by a bot. And when a certain percentage aren't addressed through that intervention, we escalate that to a secondary approach, where eventually it ends up in the hands of a human. So we're basically triaging what the bots do, the initial triage, and our staff are able to address the more difficult, challenging cases. But also, to Brian's point, there's a lot of waste in the process where clinicians are working to connect with patients. They call, they email, and so we're able to use the bots also. Our strategy is use the bots to determine the best way of connecting clinicians with patients. So we can reach out to the patient and say, well, what's best for you? Do you prefer email? Do you prefer a text? Do you prefer a phone call? Okay, it's a phone call. So do you prefer morning, evening, weekend? And we're able to get all that work staged so that when the clinician is ready to reach out, it's a much more meaningful conversation.
Sorry, I was just going to say,
go ahead.
We've had experience with the same thing on the scheduling side. So getting in and out for clinic visits. You know, the amount of time that's required of an individual to call, and if a time change, anything happens, same sort of point, this can be automatically sent out in the preferred form that the patient prefers, whether it's email or through my chart system, whatever it is, and engage to certain degrees and escalate to a person if they're having trouble or they're not hearing back or they don't think that it's being met, or if there are questions. And that cuts down on a significant amount of time that those front office staff they can work on actually scheduling new patients and working through some of the more human things that are needed rather than just automatic reminders and things going out to the patients.
We just went through where we built a automated scheduling and registration, patient information collection, and initial situation assessment. And that's just, if you think of patient's experience, right, you've got the front end, and then you've got you got up to diagnosis, then you've got the middle, which is the procedure, the treatment, or whatever it is. And you got the back end, which is the post-treatment. And one of the things I've been thinking about is, okay, how can we use automation maybe to like keep that continuous interaction between the patient and the provider? And I think there's probably ways that we can do that, but we started with what you're describing, Martin, with the appointment scheduling. So when we break these down, we can certainly show that and see if that's of any interest.
Yeah. So
Efren just joined. Sorry, you caught us right in the middle of a conversation. Efren, would you want to please introduce yourself? We had everyone introduce them and let everybody know your organization, your role, and why you agreed to join Kayak.
Sure. So my name is Ephraim Hochberg. I'm a medical oncologist at Mass General Hospital and an assistant professor of medicine at Harvard Medical School. I'm the clinical director of oncology at Mass General Hospital, which is one of the founding hospitals of Mass General Brigham. We have about, the oncology service manages about 10,000 new patients a year across 14 different sites scattered across our state and neighboring states. I'm quite interested in medical informatics. I've done a little bit of work in natural language processing, artificial intelligence, mostly in the automated interpretation of pathology reports. But my interest in this space is, as I've taken on more of an administrative role, the amount of human time spent on what appear to be repeatable tasks is a major barrier to our ability to make our processes more efficient. There's a couple of areas where those are of real concern to me, but my interest in this is the intersection of repeatable, reproducible, high quality oncology care, not requiring as many staff members to drive it as it currently does today.
Jeff, you're
Jeff,
mute.
we can't hear you.
Well, I'm sorry. I was Efren, thank you and welcome. I was just saying you joined us just at the end of the conversation. We were talking exactly about that, reducing clinician administrative tasks. One of the things that I have seen in the clinical space is a hesitancy for automation. People don't want to think that, okay, I'm having a robot make a decision, a life or death decision on a person or something. So I kind of like this one here, because I feel like the more we could get these done, the more it might help with adoption overall. You start here, you start small, think big, and then move into some of these other things like, here where you're actually, using automation to predict, patient outcomes. Have you guys seen that? Stephen and Brian, you guys, and Benjamin, you guys have got this automation out there and you're running it. Are you seeing adoption type issues that we can possibly address?
Yeah, there's definitely a hesitancy for having the bots participate, in the care process. We typically use the bots to help alert us when patients are at risk, and then be able to, like I was saying, triage the more critical patients that need intervention early. you mentioned the predictive technologies. We have begun to look more at the intelligent automation realm and looking at things like predicting hospital admissions. And so we know in advance patients that are likely to have a hospital admission in the next several months. And because of that, we can then hone in on the risk factors that are potentially leading to that prediction. So it could be something as simple as medication adherence, right? So they're not taking their medications according to their treatment plan. At that point, our escalation workflow allows the bot to, the design of it is intended to have the bot be the initial tier to reach out and say, hey, you know, we noticed you haven't had, maybe it's a provider visit when you should have had a provider visit, or you haven't been adhered, you know, maybe you have questions about your medications. And so we can address some of the lower tiered stuff through robotics, like pushing out nutrition information for a diabetic. But then when it gets to the more difficult, more complex care issues, we are able to laser focus our staff to pay attention to those more complex cases.
You know, from our perspective in the clinical world or clinical space at Mass General Brigham, we have a very limited footprint at the moment. You know, a lot of our automations right now are in the back office. But in our initial conversations, both with you know, staff here today and throughout the network that we've been having, the hesitancy is really around understanding the technology and understanding what the technology can and can't do. And really finding the right use case. I think that's the larger challenge. You know, we typically start with very small projects to gain trust and understanding of what it can and can't do, and then start to expand beyond there. So those are the types of reactions that we've gotten from both clinicians and even those that are very tech savvy. You know, let's start small and see how then we can expand from there. You know, most of our examples using at least RPA and some of our other technologies are still around, you know, physician workflows that are, as Effie mentioned, you know, transactionally based. We haven't yet gone into any area where there's actual patient outcomes associated with that. And to the point I think Stephen was making, we have some other tools that don't roll up under my group that really help us predict you know, readmission rates and things along those lines. So that, to us, at least the way we're structured, are much more around reporting elements of what we think readmission rates are going to be for certain diagnoses and things like that. And we have an entire analytics department that really focuses on developing those types of dashboards and models.
One of our future interventions is also focusing on social determinants of health. So we have tools that we can connect patients with that allows them to tap in to community programs. So if somebody, for instance, can't afford their medications, the bot can easily determine that and ultimately link them up with a community program. You know, that's just one application. It could be smoking cessation. It could be a number of social programs that are available, but the patient doesn't know that. We see a gap in from a population health standpoint, we see a gap in how we're caring for that patient. We're able to connect them with programs and make them more aware of programs that are available to them.
We have a similar process that we run, which relies on patient-reported outcomes. So the patients run a whole series of questionnaires looking at various elements of their healthcare, and then patients who score at a high level are automatically referred to exactly your example: smoking cessation, alcohol cessation. Do they have food insecurity? They have transportation insecurity. But the process of trying to remove the need to manually screen patient-reported outcomes and automate those direct referrals into the queues of the appropriate providers is a really important way of making sure the providers are comfortable with the process. They'd much rather not manually screen that, but they would also like the patients to receive the services. So where there's a value add or a win-win, I think there's much less provider hesitancy.
And what's really neat about that is, from my understanding, a lot of the patients are reluctant to talk with somebody about some of those issues. And so when it's a bot and it's all automated, they can do that from the comfort of their home with their, with the privacy of working with a bot. A lot of times you can do more with that than you could with a human-to-human interaction.
I would just extend on that, especially in cases of physical insecurity or concerns for abuse. In a scheduled appointment where the provider and the spouse is there, a potential abuse, the willingness to disclose that is incredibly low. Whereas in a one-on-one interaction with a questionnaire that's automated, with an automated output from that questionnaire, your response rates are much higher.
To jump on the end of that, the smoking cessation thing, there's very good data that the more you bring it up and the more you talk about it, the more likely they are to quit. And so being able to have automated abilities to engage the patient about that in a judge-free environment is very, very powerful for those patients to be able to offer those situations. And so that's something that can be done very easily without them having to feel bad that they're seeing the vascular surgeon again and they haven't been able to quit smoking. Engaging every time through a bot and being able to continually remind them of the importance of quitting, how to quit, and the opportunities available to them are very, very important.
So Martin, collecting the social determinants of health information is one thing, right? But really being able to, gain insights from that is where we can make more actionable decisions. So do you think, or any of you think there is an opportunity to leverage automation to make a more meaningful insights from that data?
I mean, I think there is. I think, we've touched on the first part, which is, can you engage with patients that decreases the workload for staff having to do it? And I think we've touched on that. I think that's one part. I think the ability to have engagement with them and catch patients that are falling off is very important. We get patients who cancel their clinic appointments for a variety of reasons. And, if there's a system to check in on them and collect them on the back end, they fall off, and they are the ones who come back with readmissions. And, obviously are the ones that come in long length of stays, lots of issues. Obviously, these are the folks that are at risk. I think those are two big opportunities we've talked about. I think there's obviously going to be opportunities with the more data that's collected to identify opportunities that you can pick up in the community that would help you identify potential problems. But the two caveats are things like, hey, the number of cardiology consultations for, hey, my Apple Watch told me that my heart rate has AFib or I have bradycardia, and now it's telling me I need a pacemaker. You hear it all the time. We've got to be careful with what's being put out there, that it's not that the intention of Apple to have, hey, we can now monitor your heart rate is a great idea, except that now the number of inappropriate cardiology consultations in 30-year-old healthy people, because that's what their Apple Watch is telling them, is something different. So I think we have to be very careful to take the data, look at what it's showing us, and make really good clinical judgments as to whether that's going to be important or not.
I couldn't agree with Martin enough on that. The ability to determine on the knowledge-based side where clinician intervention is warranted or not, the triage role to determine when a clinician consultation is required and when it's not is a huge waste of clinicians' time. Any process automation around the ability to determine whether or not something even hits the eyes of a human, as Stephen was saying, is a really important way of kind of workforce extension in a world where medical providers are suffering significant burnout.
So are we talking about something, let me see if I phrase this right, determine the unnecessary triage situation?
I'll give you an example I'm trying to figure out now that I'd love some insight if someone in the group has a better way to solve. We have 15 board certified hematologists who handle various abnormalities in blood counts. They receive queries from blood counts that are abnormal by 0.5% all the way to 99% abnormal, putting constraints around the ability to have a provider pulled into the mix for certain groups of blood counts. If you're within this range, you talk to a scheduler because it's probably normal. This range, you talk to a nurse. This range, you get a physician consult. And doing that across a range of 25 different blood counts would be a great way of extending my workforce and make sure that each of my providers are functioning at top of license.
I mean, from that standpoint, I mean, we're talking clinical rules, right? There's some logic, there's rules here. When we talk about a scenario where it's epidemiology, there's 800 different rules and conditions and requirements, then we have to get into very advanced analytics work and machine learning and AI, all the stuff we love to hear about. But when it's a clinician looking at a range and then saying, you know, I have to look at this, I have to look at this 800 times, and I'm just making a decision on a range of what to do next. That's a great use case to start looking at potential for automation. You know, I look at things like clinical trials all the time, assay testing and lab reporting, right? Where you have clinicians, high-paid analysts looking at bell curves, and based on the curve, making a decision on what to do. And the reality is it's got a data point, it's got a rule set, and it's got an end determined action. And if it's a control issue where you're worried where the automation could go rogue and make the wrong decision, or I as a clinician spend too much time fact checking the robot, you put the human in the loop and it goes on a list, and I just look at the outcome and not the process of the outcome, and it's a 2-second decision and not a 4-minute process. So all this could absolutely be built into an automated workflow that really doesn't even need to be an autonomous automation. It becomes the digital assistant on the desktop, right? It runs to, hey, digital assistant, same thing, right? What would you do if you were overstaffed and you have to do this? You get an assistant. So you're automating the assistant at the desktop. It's making the send determinants off the same clinical data, and it's making a recommendation to you to take an immediate action. It takes the action. You're just validating that recommendation. So that's something we could absolutely look at. I think there's a big potential there.
Yeah, that'd be incredibly helpful. We get 350 requests a week, and they're each manually triaged by a nurse, and it's incredibly expensive and inefficient.
Yep. Yeah, we were looking at a lot of similar scenarios for, you know, I think we talked a little bit about this, clinical quality control and audit. Right? We talked a little bit about sepsis before. We were talking about things like hemoglobin and variants, and did blood get administered when it should have? Was the physician that was practicing with that patient actually someone that was certified to practice with that physician, especially when you're talking about the ICU, right? We have a lot of these instances where you have hundreds of these audits that need to be performed to make a clinical outreach or to make a determination. Some of it's even reportable. And we kind of take it for granted because they might be a 4-minute activity, but when you compound that to every patient that you've seen, it's 2 to 3 hours a day. So by kind of creating that digital assistant to support those workflows, you can see a significant improvement, and you stay in control of it. So no one can ever say, listen, you made a bad decision. That's the worst thing that could happen, right? It puts you in the loop, and it's auditable. And that's probably the most important piece here out of the whole process is audit. And even though we have clinicians doing this right now, to be able to audit a lot of that is difficult, right? Because we're taking it out of the EMR and just maybe putting the outcome without the decision-making process in there. So this way, it's a full audit process. You know, I can't say that every scenario is going to be perfect. I mean, that's very difficult, but obviously the robot's going to pick up on things that we missed, and missing things is probably the problem here.
Yeah, and it's done real time too, right?
Real time, in process, but the key here is not in batch. And that's how a lot of these processes work right now is, you know, even if you use something more advanced, logic-based, create a really cool ML algorithm, the reporting comes out in batch. And then you have to get somebody to segment that and then report, you know, Jeff, we worked on the pregnancy risk. I know that was a hot topic, but that was the problem Centene had. It came out in batch, and then clinicians had to reach out to all those providers and let them know the mother was at risk after the mother had already gone home. Exactly. So, you know, same risk protocol, but how could I take action and let the robot trigger a case before the mother actually exited the provider space you want to let them know they're at risk before they go home. So it's expediting the process.
Yep. Yeah.
Accelerated care. Yep.
Yep. All right. Well, somebody go ahead.
No, so for reducing surgical waste, I know data can really play a key role here, right? Analytics and, to provide those that insights, build some intelligence by bringing in AI ML, but just trying to understand what are really some key, pain points that intelligent automation, that we can leverage intelligent automation to solve for. I know, Martin, this is your prime area.
Yeah, I think, Martin, you said pref cards. You do a lot with pref cards, right?
Yeah. So, I think the vast majority of automation and data analytics in this space have really circled around, intelligent supply chain. How do I make sure that when I've used something that it gets restocked and I know where it is and I know how to get it? How do I have it automatically pull? I know a case is scheduled. I know what needs to be pulled. Epic can pull it through and can signal what needs to be pulled. What nobody has focused on and nobody's been able to do is who's picking what needs to actually show up for the case. That's something that generally is completely, it's never updated. It's always completely wrong. Supply, the amount of hours that are spent for individuals picking supplies and preparing them for surgical cases for the next day and getting that all ready, knowing that probably less than 10% of that is actually going to be used, and then gets transported to the room, gets transported down. There's damage to those, and a lot of those have to be wasted after a certain period of time, get moved so often. That's a big issue. The big issue as well is that nobody knows what needs to be there to begin with. So, how do you do that? And I think you need data. And that's what we've done is we look at what's actually being used in surgical cases from disposables, from surgical instruments that are reusable. Reusable surgical instruments, only less than 20% are used on average for a case. We've been able to effectively cut 40% of the instruments off of surgical trays. That makes the whole process quicker, leaner. There's not more money getting pumped into sterile processing. There's only less, and it makes things much more efficient and less likely to have backlogs. But the big issue is, even if you make a change to your preference cards and say, hey, we're going to try to make a change, let's sit everyone down, let's do it. Without data, it's steeped in dogma. You remember a case that happened 10 years ago and that you used something, not, okay, well, what is the point that you say, do I need that in the room for every case just because I used it one time 10 years ago? The answer is no. And so working through that without data is very problematic, and it slips right back to where it was prior very quickly. And that's where we have really focused. And as we get more and more data, we are learning that, guess what? We're not that special as surgeons. We all do things exactly the same way. So not only can we make changes on an individual hospital level, we can actually take that data and automate it across systems and show the lean ways to do surgical cases.
Martin, the exact same technology could be put into play around what oncologic agents we stock at each of our infusion rooms. What cases go to that site on a Tuesday? If on Tuesday I never give this regimen or I never have, the likelihood I will have that happen is extremely low. And if it adds an hour once every week and doesn't take up room in my hoods and in my chemotherapy storage areas, and I have a smaller amount of held inventory of extremely expensive drugs, that's a really valuable situation that has, I think, an extraordinarily high analogy to what you're describing.
100%. And all you need is one of those very high cost medications to need to be wasted for it to have paid for the entire thing. And that absolutely. And I think it's the same thing, using the data to identify what's being done, what the physician preferences are for certain things and what they typically use, it can really make a big difference with that. So 100%.
So we are about out of time, and I figured this group, I think someone mentioned it earlier, we could talk all day on this stuff, but I feel like this has been a success. I feel like we've got a lot of great things, and this is what I was hoping for. Our next steps will then be to, and we'll communicate out to the council, we'll try to figure out, okay, Does anybody want to participate in one of these, or some of these higher priorities than others? I've tried to, just kind of highlight as I was hearing everyone express their interest in this. So yeah, we'll do that. In the meantime, as I said earlier, if anybody out there listening in the audience wants to become a member or knows of someone in your organization that you think could benefit from this, or the council could benefit from their participation, absolutely feel free to reach out to me. We'd love to have the conversation. That's how this group got started, and that's how we want to grow this. The more we can grow it, the faster these things will come to reality. Jason, anything you want to add?
Yeah, and I think that's the important part. Like I said, there's plenty of opportunities for people to come and present and talk about the great things they're doing, and we should do that, right? We should encourage each other and be academic. We really form the kayak, right? We use an analogy because we're all in the boat. Benjamin, you talked about how your automation is still very back office, that you want to expand and find the right use cases. That's the problem. I'm not saying you're the problem. I'm saying that's the problem across automation and technologies in general in healthcare, is we come across these really great use cases and deploy for our organization, but rarely do we share them. We're an academic association here, right? What's good for one, it tends to be good for other. I realize there's customization, but it's about how we get there. And we find that when we create these sort of mechanisms, not only do we get our thoughts out, but we could start solving problems. We did one at the early stage of COVID vaccination programs for registration of mass public health. And I got a couple of program directors from different hospitals together. One of them had a great idea and the rest of them implemented it. So when we come together like that, I think we'll find some cross-associable use cases that we can generate value from. And Benjamin, when you talk about finding the use case and deploying them, if half the organization here finds a really solid use case and it's something that you can bring to your team and say, listen, this has been done before and this is the value, the adoption is so much faster and easier, right? So that's what I would encourage the team to keep progress on, is let's grab some of the use cases that we're starting to discover. I think there's a couple key ones that we need to tweak out, create program groups, prototype them or share the stories and how it was delivered, and then really socialize them amongst the group. It'll grow the program, it'll improve patient outcomes and reduce clinician burden that much faster.
Absolutely. Well said. Thank you, Jason. So panelists, thank you so much. I know you guys are busy, you're in high demand, and I just could not be more pleased with your participation today. Look forward to everything that comes after. Quick plug for anyone who's on, Jason and I will be at HIMSS. So we'll be having these types of conversations, and I'll be scouting for more council members. So if any of you know of someone in your organization that's going to HIMSS, give them a heads up. We haven't started marketing yet. We don't have all the details. And with that, again, thanks everyone. And it's been fantastic. Appreciate it.
Thanks everyone.
Thanks everyone for the time and your continuous care. Take care.